Great. Thank you, Charlie. And thank you, everybody, for submitting your responses. I think it's really important for us to get a good feel in the room. I think what we're seeing here is the diversity of issues that need to be tackled, that we need to be addressing, and hopefully we can have discussions about these throughout the day. So these, I believe, are also coming in via webcast. Is that right? Does anybody know how many people we have on webcast? There's about 80 on webcast. Okay. Good. So I want to thank the folks on webcast as well for participating and continuing to be with us throughout the day. Good. So next we have Jim Marks, and I'm going to provide an introduction to Jim so he can provide some comments from RWJF's perspective. Jim is the Executive Vice President of the Robert Wood Johnson Foundation, and he joined the foundation in 2004 and currently oversees all program, communications, research, and policy activities in support of the foundation's efforts to build a culture of health. And prior to joining RWJF, he served as the Assistant Surgeon General and Director of the National Center for Chronic Disease Prevention and Health Promotion at the CDC, where he developed and advanced systematic ways to prevent and detect diseases such as cancer, heart disease, and diabetes, reduce tobacco use, which is interesting, sitting next to Adam over there, who just gave us a story about a significant tobacco use, and to address the nation's growing epidemic of obesity. A national leader in public health, Marks has received numerous awards from federal, state, and private organizations. He was elected to the Institute of Medicine, now the National Academy of Medicine, so he's one of our members, in recognition of his accomplishments in epidemiology and public health, and has published extensively in the public health scientific literature. He received his medical degree from SUNY at Buffalo and trained as a pediatrician at the University of California, San Francisco. Later, he was a RWJF clinical scholar at Yale, where he also received his MPH. So welcome, Jim.
Thanks, Kimber. Sure, thank you. Thank you. It's great to be here. I'm glad that the trains were on time. And I want to thank all of you for coming. First to the Culture of Health Program Advisory members who are here. I want to thank you on behalf of the foundation, on behalf of Dr. Risa Leviso-Mori, our president, and myself. I want to thank you, the attendees, and the people that are online. And of course, I want to thank the committee members and the National Academy of Medicine staff who prepared that first report on community-based solutions to promote health equity. Let me say that the report is what we hoped for, but it also exceeded our expectations about what would be able to be accomplished with the first report. You'll hear about it later this morning, but I might not get a chance to comment on, so I wanted to do that ahead of time. There are some remarkable elements in that report. First, that it actually calls out from the National Academy of Medicine the issue and the role of structural racism and poverty as huge drivers of inequity in our society. That's an important statement for all of us here and for the nation to be aware of, that the National Academy of Medicine comes to that conclusion from their review of inequity and the science behind it. Secondly, there's the hopeful element, the hopeful note that the examples of what communities around the country are doing, they take 9 communities and build out those examples. And those examples, those stories, show why we felt at the foundation it's so important to support this work of the National Academy on a Culture of Health and Health Equity. We need to elevate and make visible what is happening around and to sustain that dialogue about what it is necessary for us as a nation to address inequity in the nation and in our communities, that is, inequities especially between groups of people. I just came from Richmond. I took the early morning train up from there. In Richmond, the Richmond Memorial Health Foundation and its board has just decided that they're changing their whole programming effort to embrace the issue of culture of health, social determinants of health, and the need for health equity for the greater Richmond area. And this was their coming out party for the region. They had an event where they had over 100 leaders from around the community come, from the healthcare community, from the education philanthropy in the area, and from public, and the mayor came, and nonprofits in the area. The initial report here was explicit that the health equity challenges about race, very importantly, but also affecting many other issues and discriminatory policies like those affecting the LGBTQ community, or on income and education, gender, those with mental and physical challenges. Those are also critically important for our nation. So that even as we think of health equity as the outcome, we know that health and well-being are nurtured, they are protected and preserved where people live, learn, work, and play. That's language that we've started to use at the foundation about making more colloquial the academic term social determinants of health. There are 3 points I want to make today in my remarks. First is some context about health equity, health disparity, and fairness and opportunity. Those of you who are familiar with public health know about the iconic John Snow investigation in London in the mid-1800s. He mapped the deaths from cholera and during an epidemic, and he found that the people who lived near and got their water from the Broad Street pump were more likely to get ill and die than people who lived elsewhere. When you looked at his map and investigation, at its core, it was about noticing a disparity, a difference between neighborhoods in deaths from cholera, and then taking action by removing the pump handle from the Broad Street well pump. He did it with the permission of the St. James Parish Board. If you will, he had to go to the official agency and get a policy decision. So at the very core of our field in public health, it was about noticing a disparity, not between racial and ethnic groups, probably not even between education levels, but a disparity nonetheless, and then taking action. William Fagey, former director of the Centers for Disease Control, former president of the American Public Health Association, and member of the National Academy of Medicine, said that in his presidential address at the APHA, the philosophy of public health is social justice. And the primary goal of public health is to reduce or eliminate differences in mortality and morbidity between populations. In so many words, he stated that disparity reduction, regardless of its source, and striving for equity in health is not part of what our field is about. It's our field's central purpose and fundamental goal. We often focus on race and income and education, because health and well-being differences linked to those are large, persistent, pervasive, and systemic, affecting almost every disease and injury. The importance of health equity, of fairness, rose to the top at our foundation as we thought about what our next mission should be, our next vision, and that turned out to be Culture of Health. I want to expand on that just a little. It is about fairness, especially fairness in the opportunities for good health. That is the affordability, the safety, and the convenience of healthy choices where we live, learn, work, and play. It's about equity in health itself insofar as possible, not between individuals, but between groups of people where basic biologic differences cannot be blamed for that disparity. This is actually quite parallel to what we do in clinical care. I'm a pediatrician, took care of patients for a while, but if you have hypertension and you go to your doctor and he or she gives you medication and it doesn't lower your blood pressure enough, they give you more medication. You get what you need for the severity of the condition that you have and the responsiveness you have to the medication. Also, in clinical care, they have a standard that they're going to try to treat you for, and that usually is based on the blood pressure or cholesterol level that's associated with the best outcome, the longest life, the least likelihood of the complication, heart disease or whatever. So in addition to opportunities, in addition to equality and health itself, it is about equity and hope. People with hope can and do make different decisions for themselves and their families than those that are without. Now that might seem a bit of a stretch for our discussions, but there is actually a randomized trial of an injection of hope to mothers in Oklahoma. Poor women, some of them, when they had a new baby, were given a $500 college fund, a 529 plan, and others were not. Now, those of you that have kids looking at college or recently went to college know that $500 is a drop in the bucket. And those of you who are not in that situation in life, probably many of you actually went to college, and you too know that $500 is a drop in the bucket. By age 5, they found that the mothers who had gotten that $500 529 plan, their children were doing better. Their children were working better with others. They were more kindergarten ready. And the mothers themselves thought differently about their children's future. Now, we don't want to give people false hope, but the notion that hope is so important for how people respond is something else we have to recognize as part of the goal if we're going to succeed as a nation. My second major point is that we want the movement towards good health and well-being, and we've been using the term well-being more and more in our thinking, to be happening in communities everywhere. As leaders in health, we have to speak to the responsibility our nation has to everyone, with a special responsibility for those of us at great risk or in great need. And I also have a Martin Luther King Jr. quote. In his well-known statement, he said, "Injustice anywhere is a threat to justice everywhere." Picks up greatly on the quote about health care. This means that if injustice, think of that as inequity or disparity in health, is accepted unchallenged anywhere, then there's the risk that the idea of unjust societal behavior and structures can become accepted too, and they can spread, and they can gradually corrode our shared sense of community and nationhood. The implications of this led us to recognize that widespread application of new effective interventions really is crucial to the notion of a culture of health. Successful demonstration programs in a few communities or hospitals or clinics often don't spread. Many good studies, many good improvements fade away. The third point is that we are interdependent as a nation and as communities. The major health problems of our time, especially as related to fairness and equity in health and well-being, cannot be solved by health care alone. They cannot be solved by public health alone. All of our nation's institutions, public, private, and nonprofit, have important roles to play, even if they do not think of their purpose as fundamentally being about health and well-being. Every organization or sector of our society, business, healthcare, academia, schools, urban planning, parks and recreation, banking and finance, agriculture, childcare, has as their core their core purpose, the value they bring to making a community a good place to live, to raise a family, so people can have warm relationships with neighbors and friends, so they can thrive and succeed. This was a key point in the just released report with its great examples from communities around the nation. And central to that third point is that our nation's institutions must see that what they do in their decision-making and actions routinely include an assessment of how they will help people do better, and not see that as something additional they need to think of, something that's in addition to their day jobs. That is part of their core purpose for our society. The specific individual diseases, injuries, or risks that have been the focus of much that we've worked on as a foundation, and many of you in this room in health and healthcare, are really the symptoms that emerge in individuals from the effects of more fundamental causes. That is the underlying finding, if you will, of the report that is just released, and why we see this as the needed ongoing effort for the National Academy. Clinicians know that often symptoms must be treated, but cure and the eventual elimination of suffering comes from addressing those root causes that Victor referred to. This calls for a transformative thinking in how broadly we think about how we improve health and well-being. We in health have generally thought of as good health as what people want. It isn't really. What they want is a good life, fulfilling, enjoyable, warm relationships, meaningful work. They're like me. I'm a grandparent. I want to see my grandkids. I want to play with them. I want to watch them grow up. Maybe I'm at a stage of life where I need to keep working, or I want to keep working because it's fulfilling, or I want to volunteer, or I want to travel. My best chance of having that kind of life is watching what I eat, not smoking, exercising, getting my flu shots. That's why we want good health. And it is part of our responsibility in health and healthcare to embrace that sense of the value of health. It is a crucial base for the kind of life we and the members of our communities want. The narrowness in our thinking about health has greatly influenced our civic leaders and the public so that they've not been nearly as aware of how our society is organized, what our policies foster or inhibit, what our communities encourage, our institutions support. Those are all equally as fundamental causes of good or ill health as are the biologic ones. It's research that turns disease and injury from fate's misfortune or bad luck or accident into biologic understanding and potential control. But that research then turns its understanding over to society, and whether it's in clinical care or in community health, or in education or in agriculture, or almost anything else. In the end, it's the policies and the laws and the practices, the scaffolding of a society's culture that must transform research into impact on disease, injury, improved health. The policies and social structures inside clinical care and public health, outside and beyond the classic health field, become part of the causal web related perhaps to disease or injury directly, but certainly to the rates and distribution of that disease or injury in our people and communities. That is, to the size and distribution of disparity. We're at a watershed time in our nation's history. We have to be honest with ourselves. Technologic advancement, where our nation's leadership is unquestioned, has failed to rein in the growth in medical care costs, nor has it even enabled us to have better health relative to other countries of similar wealth and development, according to standard big picture measures like life expectancy and infant mortality. That brings me to a culture of health. At the foundation, after a really extensive review of what we should be doing going forward, shortly after our 40th anniversary, we concluded we must do all we can to help our nation build a culture of health, and that enables all in our increasingly diverse society to lead healthy lives now and for generations to come. That's become our vision and commitment. It means building a society-wide convergence on the deeply held shared value for health and well-being, that all parts of our society, in rural areas, in cities, our public agencies, and the private sector work together so that all can have good health and good quality health care becomes accessible and affordable. As a nation, we've had an enormous imbalance regarding where we look for sources of health and illness and solutions to disparity. Some might have thought of the National Academy of Medicine as an unusual institution to ask to take a look at health and well-being for our society as a whole. You're here because of your connection there. There is no other institution that speaks on medicine and health with the authority and gravitas of the National Academy of Medicine. It speaks about science and what it shows us is necessary for success. The National Academy can also speak from and to the heart about the values that are inherent in medicine and the protection of health. Medicine has always been about the application of science to those who are in need, who are suffering, or at risk. Medicine and public health as applied sciences also know that, like an oncologist, that better treatment for cancer is coming from future research. But like that oncologist, they need to treat the patient that is in front of them now with what they know now. There is an urgency to act, even if the science is incomplete or immature. So, as you discuss the next reports and forums, where this work should go, I ask that you think broadly about what affects health and well-being, the characteristics, and even the stories of the people whose circumstances make their chances for healthy choices, their chances for good health, their chances for being truly hopeful about their future, almost impossible. And finally, to ask and show what we, you, as leaders in and of our nation can do to make working together for a culture of health and well-being the duty and privilege it is. Thank you. It's been great to see the report and great to see how this is coming together.